Implementing a standardized wound assessment protocol to improve documentation, consistency, and support patient outcomes in an outpatient wound care clinic. Slide 1, title page. Hello, my name is Vanessa Cosillo. This presentation was prepared for Professor Michelle at American Centennial College of Nursing and Health Sciences at Post University. I am presenting my BSN 499 capstone project proposal for leadership consideration. The project is titled Implementing a Standardized Wound Assessment Protocol to Improve Documentation Consistency and Support Patient Outcomes in an Outpatient Wound Care Clinic. The purpose of this presentation is to summarize the clinical problem, explain the project matters to nursing practice and the nursing profession, and request support for a realistic quality improvement pilot. My focus is not to replace provider judgment or conduct a research experiment. Instead, I am proposing a practical improvement in how wound assessments are documented and communicated in an outpatient wound care setting. The proposal is based on evidence showing that wound assessment requires consistent core data, trained users, and structured measurement methods to support communication and monitoring over time. Slide 2, Introduction and Purpose. I am presenting this proposal as a registered nurse and BSN capstone student to the leadership team, administrators, and clinical stakeholders who have the authority to approve a quality improvement pilot. My role is to identify a meaningful practice problem, review the available evidence, and propose a feasible process that can be evaluated with measurable outcomes. The purpose of this presentation is to request approval for a 12-week pilot of a standardized wound assessment protocol. The pilot would use a concise assessment checklist, staff education, competency validation, and chart audits. The project is relevant because wound documentation must be complete enough to support comparison across visits, communication with a wound care provider, and early recognition of clinical changes. Coleman et al. 2017 support the use of a minimal data set for wound documentation, while Smet et al. 2021 emphasize that wound assessment tools must be selected and applied carefully because measurement evidence varies across tools. Slide 3, Project Topic Summary. The project topic is a standardized wound assessment protocol for eligible outpatient wound care visits. The problem to be solved is inconsistency in wound assessment and documentation. In practice, one nurse may describe drainage, tissue, wound edges, or peri-wound skin differently from another nurse. A record may contain enough information to describe one visit, but may not contain consistent information that allows the team to compare progress over several visits. The proposed project would guide nurses through the same core wound assessment elements during each eligible visit. These elements include wound type and location, length, width, depth, tissue characteristics, drainage, wound edges, peri-wound findings, pain, signs of infection, photographs or measurements when appropriate, escalation to the provider, and patient education. Coleman et al. 2017 support the use of common wound assessment data elements, and Muhammad et al. 2022 demonstrate that workflow design is important because an assessment method must also be feasible in an outpatient setting. Slide 4, Problem and Relevance. The clinical problem is not simply that documentation is imperfect. The large concern is that inconsistent wound documentation can weaken continuity and make clinical trends harder to recognize. Chronic wounds often require repeated outpatient follow-up, so the care team must compare findings from one visit to the next. If wound size, tissue, drainage, edges, peri-wound skin, pain, and infection indicators are not recorded consistently, treatment decisions may be based on incomplete or difficult to compare information. This project is directly relevant to my nursing practice because nurses are often the first clinicians to identify changes in a wound. A standardized process supports critical thinking by organizing the assessment without removing individualized clinical judgment. Smet et al. 2021 found that chronic wound assessment tools differ in the strength of their measurement evidence, which means nurses must use structured tools thoughtfully. Bates-Jensen et al. 2019 also demonstrates that reliability depends on training and clearly defined wound characteristics. The project therefore strengthens nursing assessment, documentation, communication, and patient safety. Slide 5. Background of the problem. The background of the problem begins with the nature of the wound care itself. Chronic wounds are monitored over time, and changed in wound size, tissue, exudate, pain, and peri-wound condition may indicate improvement or deterioration. When assessment elements are not captured in a comparable way, the team may struggle to determine whether the treatment plan is effective or whether the patient needs a different intervention. Coleman et al. Developed a generic wound care assessment minimum dataset to address inconsistent assessment criteria. Smet et al. Reviewed chronic wound assessment tools and found that evidence for reliability, validity, and responsiveness differed across instruments. Bates-Jensen et al. Demonstrated that a structured tool can be completed efficiently, but reliability still varies by wound characteristic and clinical context. These findings support a protocol that indicates clear definitions, staff education, and auditing rather than simply adding another form to the record. Slide 6. Why this issue is important. This issue is important because the wound assessment is the basis for many downstream decisions. Based on the assessment, the provider may change the dressing plan, order cultures or imaging, adjust pressure relief or offloading, schedule debridement, or escalate the patient to a higher level of care. When important assessment elements are missing, unclear, or inconsistent, patient safety and continuity of care may be affected. The proposed objectives are measurable and practical. First, all staff expected to use the protocol will complete education and competency validation before implementation. Second, at least 95% of eligible visits will contain a completed standardized assessment. Third, the mean documentation completeness score will improve by at least 20 percentage points from baseline. Bates-Jensen et al. Support the value of training for consistent assessment, and Rodriguez, Valiente et al. Show that gaps in education, confidence, and organizational support can affect wound care practice. Slide 7. Implementation approach. The implementation approach is intentionally simple because a protocol must fit the actual outpatient workflow. The first step is to develop the protocol using core wound elements supported by the literature. The second step is to obtain leadership and provide a review. The third step is to educate nurses and validate competency with case-based examples. The fourth step is a limited pilot, followed by chart auditing, feedback, and revision. Several stakeholders are necessary for the project to succeed. Registered nurses are the primary users of the protocol and should help review the workflow before launch. The wound care provider or medical director must confirm that the required assessment elements support clinical decision-making. Patients are external stakeholders because they participate in repeated assessments, photographs, education, and follow-up. Clinic leadership must approve education, time, chart review, and workflow changes. Coleman et al. Support a minimum dataset approach, and Rodriguez, Valiente et al. Demonstrate why staff engagement, education, communication, and organizational support are important during the wound care improvement efforts. Slide 8. Benefits and organizational impact. The anticipated benefits are more complete and comparable documentation, clearer interdisciplinary communication, earlier recognition of concerning changes, and stronger quality data. When the same core elements are assessed during each eligible visit, nurses and providers can easily compare wound progress over time. A structured record can also reduce the need to clarify missing information after the visit and can strengthen handoffs among nurses, providers, and other services. The organizational impact includes improved process, reliability, and a measurable basis for future improvements. Chart audits can identify common omissions, education needs, and electronic record fields that require revision. Coleman et al. Support the use of consistent wound data, while Smet et al. Support careful selection of structured assessment elements. Muhammad et al. Further shows that well-designed wound assessment workflow can improve efficiency. The project cannot guarantee faster healing, but it can improve the reliability of the information used to guide treatment, education, escalation, and future outcome evaluation. Slide 9. Realistic project timeline. The proposed timeline is a 12-week pilot. During weeks 1 and 2, the protocol, chart audit, checklist, and education materials will be finalized. Week 3 will be used for leadership and provider review to confirm that the protocol is clinically appropriate and feasible. Week 4 will focus on staff education, the POS test, and competency validation. Week 5 through 8 will be the active pilot period. Nurses will use the standardized protocol for eligible outpatient wound visits. Week 9 through 11 will include formal weekly chart sampling, unit level feedback, and workflow adjustments. Week 12 will be the final evaluation period when the team reviews whether education, protocol use, and documentation completeness goals were met. This stage timeline is realistic because it allows development, approval, implementation, and evaluation without assuming major new technology or staffing changes. Slide 10. Potential budget. The potential budget is designed for a low-cost quality improvement pilot. Most of the projected expenses is indirect staff time. The budget estimates 1 hour of education for 6 nurses at approximately $60 per hour, 8 hours of nurse champion time, and 6 hours of chart audit time. Direct costs are limited to printing, lamination, and training materials. The estimated total is approximately $1,055, although actual labor costs would depend on the clinic's salary structure. This budget is realistic because the project does not require a new wound imaging platform, new staff positions, or major equipment. Existing electronic health records, functions, meeting time, and clinic computers will be used whenever possible. Muhammad et al. Show that technology can reduce wound assessment time, but the capstone can begin with a standardized checklist and existing resources. Rodriguez, Valiente et al. Support investing staff time in education and organizational support because training gaps and institutional barriers can affect wound care quality. Slide 11. Evaluation Plan. The evaluation plan is designed to determine whether the project changes the documentation process. The first measure is education completion. All nurses expected to use the protocol must complete education and competency validation before implementation. The second measure is protocol adaptation. At least 95% of eligible wound visits should contain the completed standardized assessment. The third measure is documentation completeness, with a target improvement of at least 20 percentage points from baseline. The sampling plan includes 30 baseline charts reviewed before implementation and 10 eligible charts per week during the pilot. The same standardized audit tool will be used for baseline and post-implementation review, so the comparison is consistent. Coleman et al. Support measuring core wound documentation elements, and Bates Jensen et al. Support the value of trained structured assessment when the wound characteristics are being evaluated. The project will report aggregated results rather than individual staff performance. Slide 12. Evaluation Tool. This slide shows the actual evaluation tool that will be used for chart auditing. Each eligible chart receives 1 point for each required element, for a maximum score of 10. The elements include the wound location, wound type, measurements, tissue description, drainage, edges and peri-wound findings, pain, infection indicators, provider escalation when indicated, and patient education. A score of 9 or higher will be considered complete, although the primary project measure will be the mean completeness score before and after implementation. The checklist is locally developed for quality improvement but its content is grounded in published wound assessment evidence. Coleman et al. Support wound assessment data elements. Bates-Jensen et al. Support structured domains such as size, tissue, exudate, edges, surrounding skin, and related clinical findings. Sment et al. Support careful selection of assessment elements because measurement evidence varies across chronic wound tools. The checklist therefore provides a practical evaluation tool while remaining aligned with scholarly evidence. Slide 13. Validated instruments and sampling. The assignment requires both a data sampling process and validated instruments. The evaluation plan uses a local chart audit checklist, but the checklist is informed by validated and consensus-based tools. The Bates-Jensen Wound Assessment Tool provides structured wound characteristic domains, although the cited reliability study focused specifically on pressure injuries. The pressure ulcer scale for healing includes size, tissue, and exudate measures that are commonly used to monitor healing trends. The Coleman minimum dataset supports the inclusion of consistent wound documentation categories. The sampling process is designed to be feasible in a small outpatient setting. 30 baseline charts will provide a snapshot of current performance. During the pilot, 10 eligible charts per week will be reviewed to track adoption and completeness. At weeks 12, the results will be compared with baseline findings to determine whether the protocol should be sustained, revised, or expanded. This uses validated concepts without claiming that one instrument is appropriate for every wound type. Slide 14. Key measurements and results used. The project will use 3 major measurements. Staff readiness will be measured by education completeness, the POSTUS score of at least 90%, and successful competency validation. Protocol adoption will be measured by the percentage of eligible charts containing the completed standardized assessment. Documentation quality will be measured by the mean audit checklist score and the frequency of missing assessment elements. The result will be used to improve the process rather than punish staff. If one element, such as para-wound assessment and patient education, is repeatedly missed, the team can provide targeted coaching or revise the electronic record field. If completion is high, but the staff report that the protocol takes too long, leadership can review duplication and workflow design. Coleman et al. Support the value of consistent wound data, and Rodriguez-Valiente et al. Show that education, communication, professional confidence, and institutional support must be addressed when improving wound care practice. Slide 15, Barriers and Mitigation. 2 potential barriers are expected. The first is resistance to change. Staff members may believe that their current assessment method is already adequate, or may worry that the protocol adds another documentation burden. Rodriguez-Valiente et al. Show that wound care barriers may include knowledge gaps, professional insecurity, communication problems, and institutional constraints. Resistance should therefore be addressed through early involvement, explanation of the patient safety purpose, case-based education, and unit-level feedback rather than judgment. The second barrier is limited time and poor workflow integration. A standardized protocol can fail if it duplicates existing fields or does not follow the sequence of the patient assessment. Muhammad et al. Demonstrate that assessment workflow affects time and efficiency. The mitigation plan is to pilot the protocol before full implementation, remove duplicate fields, arrange the checklist in assessment order, and use audit findings to refine the workflow. A nurse champion and active leadership support will be important throughout the pilot. Slide 16, Conclusion and Closing Summary. In conclusion, the standardized wound assessment protocol is a feasible quality improvement project for an outpatient wound care clinic. It addresses a meaningful documentation problem through evidence-based assessment elements, staff education, competency validation, and chart audit feedback. The project does not require major new equipment or a large direct budget, but it does require leadership approval, staff participation, and a commitment to use the results for improvement. The strongest reason to approve the project is that wound care depends on reliable information over time. Coleman et al. Support the use of core wound documentation data. Smet et al. Support thoughtful selection of assessment tools. And Bates-Jensen et al. Show that structured assessment can be feasible when clinicians are trained. I recommend approval of the 12-week pilot, evaluation of the measurable objectives, and use of the findings to decide whether the protocol should be revised, sustained, and incorporated into routine outpatient wound care. Slide 17, References. This slide begins the APA reference list for the scholarly sources used throughout the presentation and speaker notes. The articles by Bates-Jensen and colleagues, Coleman and colleagues, and Muhammad and colleagues support structured wound assessment, minimum documentation elements, reliability, and workflow feasibility. The full text articles are included in a separate zip file required for submission. Slide 18, References. The final reference slide completes the scholarly support for the proposal. Rodriguez Valiente and colleagues provide evidence concerning nurse education, confidence, documentation, and communication, and organizational barriers. Smeet and colleagues provide these systematic review that support careful selection and interpretation of chronic wound assessment tools. Together, the 5 articles provide the evidence base for the proposed protocol, education plan, and implementation strategy and evaluation approach.